privilege and pleasure to welcome Dr. Kathryn Xixis today to give our pediatric grand rounds in neurology. Dr. Xixis joined us here at ETSU in 2015 after having finished her residency and then her child neurology fellowship at Duke University Medical Center in Durham, North Carolina. Prior to that, I believe she had done her undergrad training in UNC Chapel Hill, followed by her medical schooling at the Brody School of Medicine in Eastern Carolina University. I have worked closely with Dr. Xixis since she's been here, and I'm really excited for you to listen to today's grand rounds because I can assure you she is a wonderful presenter. She has done many, many active things with presentations since being here with us, starting off with the Southwest Virginia Pediatric Conference yearly, even prior to being here, and since she has been here. She was responsible for and in charge of bringing a pediatric neurology fellowship from the American Academy of Pediatrics with a visiting professorship from Dr. Sucheta Joshi in the summer, which also then led to the ECHO and starting of ECHO sessions through our department here. If you haven't listened to one of Dr. Xixis' ECHO presentations, I would strongly advise you to join us in the ECHO sessions that happen on a monthly basis. I believe there's one coming up pretty soon. We can get you more information from our department or through the CME department on those. Dr. Xixis is a member of the AOA, elected when she was in medical school, and just has had so many presentations and publications that I would take us away from the lecture in listing all of those. So without further ado, Dr. Xixis.
Thank you. Okay, can you guys hear me, I think? Okay, all right. Hi, everyone. If I don't know you, I'm Kathryn Xixis. I'm glad you're here. So today I'm going to talk a little bit about movement disorders in childhood. This is a very big topic. It's a topic that we could talk for an hour about one or two of these diseases, and this is an overview of kind of all of them. Okay, so this is really, truly an introduction. So I have no disclosures. So let's think about, when we talk about a movement disorder, we're talking about an entire classification of problems, right? So we can think about these as increased or decreased movement. And when we think about increased movement, we talk about hyperkinetic movements. That's most of them. So that's our tics, that's our stereotypies, that's our chorea, that's dystonic posturing. And then we have hypokinetic movements. We think more in the Parkinson-like department. So this is just a general way of thinking about movement problems. These are the very broad categories we're going to touch on today. Benign movement disorders, tics and stereotypies, acquired, genetic, and psychogenic movement disorders. We are going to focus on the basic workup, the basic differential, why you might think about one of these diseases. We are certainly not going to go into every detail about them. We just can't. Each of these, like I said, could be an entire category by itself. And the real reason I thought that this would be a good lecture is I get a lot of phone calls, and some of them are a little hotly contested about if it's not a seizure, what is it? What could it be, right? We get very upset that that's not the answer that we hear. So there's a lot of things it could be, and that's what we're going to talk about right now. So first, benign movement disorders, not really a disorder. These come in a wide variety of types. They are not well understood. We do think that it has something to do with the development of the brain over time as the infant brain kind of develops neurologically. Most of these are going to be outgrown by early childhood type area, and they're going to resolve over time. These happen in kids that are normal neurologically, that have a normal neurologic exam. They also happen in kids who don't have a normal exam, but certainly are not indicative that there's something else going on. So this is a big list. We're going to talk about each of these very briefly in just a second. So as you can see, some of them show up in the neonatal period, some of them in infancy, and some of them in early childhood. In the neonatal period, we talk first about jitteriness. That's a very general word, right? It can mean a lot of things. When we see jittery movement, we see tremoring. Sometimes it seems a little bit rhythmic, and we often see that here a lot in drug withdrawal babies. So that's very common, unfortunately, here. Certainly, people who have HIE, so hypoxic ischemic encephalopathy or other brain damage, as well as people with electrolyte abnormalities, all of those could be underlying causes of jitteriness in the neonate. Benign sleep myoclonus in the neonate is also fairly profound. And I will say, babies do weird things, and it looks really weird. And I agree. We have captured a lot of babies on EEG having sleep myoclonus. It's clearly not a seizure, but I certainly understand why you were concerned. Like, it looks very weird. It can be very aggressive and semi-rhythmic. So certainly could be mistaken for a seizure, but is definitely on the differential of jerking in a neonate. So let's move on to infancy. We also have benign myoclonus of infancy, so same idea. Again, babies do weird things. It does look weird. So certainly ruling out a seizure or infantile spasm, if we're talking about a little older infant, is going to be a very important piece. There is something called spasmus nutans. That is a triad. It's kind of a classic, might be on a board exam kind of triad. It has head nodding, torticollis, and nystagmus. Usually it is something that comes on with no other problem. It's kind of in the 6-month to 18-month kind of range, and often it will go away on its own. However, it's very important in this particular situation to rule out that there is an underlying tumor or other abnormality that has caused it. We also have infantile gratification spells, which are posturing, rocking. Kids will have stiffening of their legs. And these are often mistaken for seizures, actually. People say their legs got stiff and then they got red in the face and they weren't responding. And so becomes a very important piece of differential diagnosis in this age group. All right, we're going to look at a couple of these in a minute on video. So shuttering spells, also very common, typically a very benign finding. Also can be mistaken for seizures, though. Kids will grimace. They're often eating when this happens, and they will shake, and we're going to see one of them in a minute. And those shivering, kind of intense shivering spells can look very weird, but are also very common and are not scary in terms of their etiology. We see dystonic events that occur in kids. We see paroxysmal torticollis in kids and tonic upgaze in these early young kids as well. I would point out that the paroxysmal torticollis certainly could just be an event, could just be something that's happening as a benign movement condition, but also can be associated with genes or a precursor of migraines. So sometimes kids who have episodes like this may go on to have migraines or may have an underlying gene related to migraine. Same thing for the upgaze piece. So certainly you can have this. These are benign disorders. They don't necessarily associate it with something bad, but it's going to be really important, again, to rule out a structural malformation that's causing this kind of tonic upgaze. So certainly seizure, but also something increasing pressure in the brain. And lastly, in early childhood, there are head nodding movements. They can happen in different directions. They can be rhythmic. They can be sustained. Unless it is by off chance associated with a nematode from Africa, it is typically a benign finding, and again, is something that will go away over time. So first, we're going to look at a shuttering spell, if I can make it work. You will have to watch for just a minute. I stole these off YouTube. I had a better one, but it was one of our patients, so I wasn't allowed to use it.
Okay, Olivia, we're going to have some apple.
You don't need to hear it. Just watch. Kid is eating, so in a high chair. Pretty classic.
Where's that shudder?
Did you see her kind of tighten up? The face is grimacing. She's kind of shaking. Her shoulders shake. Not as pronounced, like I said, unfortunately, as the other example that is a HIPAA violation. So, but, you know, certainly people say they didn't respond for a second. You know, the story that you would hear from a parent could very much sound like a seizure, which is why videos are going to be so helpful. Okay, everybody see that?
Yeah.
We understand the shuttering spell?
It's happening more
Okay.
often.
Yeah.
All right, so now we're going to look at a self-gratification spell first in an infant. It's also going to take a minute to see.
Does that ever get worked up as like a swallowing disorder?
Probably. In my world, it gets worked up as reflux or seizure, usually. So mainly you're gonna see the lower extremities here in a minute. It does take a couple seconds here. So you see how they're kind of semi-rhythmically jerking now? Kid might kind of holding her arms up. Looks like she might be holding her breath a little bit. So again, a parent comes in and gives you this description, you're gonna think, well, that sounds kind of weird. I'm kind of nervous. And now the same kid, as an older kid, so the family got a diagnosis that that's what it was. And so they understood that, but then took a video later on. So this is a kid, also takes several seconds. She's at the table, same kid, that's the baby.
Hi. What you doing over there?
Mom, can I take a picture?
When I'm done. What you doing?
Two.
So she's gonna start rocking in a minute, kind of rocking. Her back is sort of stiff. She's gonna look like she's not really responding to you. Again, all concerning based on that description.
Very nice.
There she goes.
I need to pick up the gas.
But her mental status is really intact, right? Even though she's not responding. So that can be confused. And I will tell you that we had a kid in our clinic who we kept getting phone calls that the kid is having seizures, the kid falls down, the kid gets stiff, and the kid gets red in the face. When we got to the bottom of that story, it was actually the kid lays down, then his legs get stiff, then he gets red in the face, which is a very different story, right, compared to what, the first story sounded like. All right, so let's talk about tics. We're going to change gears. We're going to talk about tics and stereotypies. These are by far going to be the most common things you're going to see in a primary care clinic. So let's talk tics first. Tics are the most common movement disorder in childhood, so very common. You're definitely going to see them. They come in two big categories, so motor or vocal/verbal. And most commonly in the motor category are facial or eye movements. So eye blinking, maybe grimacing, maybe head movements, those sorts of things. But any part of the body can be involved, so they can be much more complex movements as well. Vocally or verbally, you may hear grunting or throat clearing, kind of nasal noises, things like that are pretty common. So the classic description of a tic is that it's stereotypical and it's repetitive, but it does fluctuate over time. So if you're seeing a kid for the first time and they started having tics last week, maybe it hasn't fluctuated. But when you see them 3 years later or 2 years later, they're gonna say, first I did this and then it kind of changed into this and now I also shrug my shoulders, and it's gonna kind of change over time. It waxes and it wanes. That includes over time as well as throughout the day. It's not always the same. There is a feeling of obsession and compulsion. I feel the need to do it, and when I do it, I feel better. And that is described very well in relatively young children. So if you ask them, a lot of them can tell you that. It is suppressible, so maybe they have a big presentation, so they're not doing it right then, but they can then kind of do it later to release that pent-up feeling. And it is suggestible, so the more you talk about it, the more they're gonna do it. You can often see it in an exam room because you're talking about it, and you talk about it long enough, the kid will do it. Some parents get very upset. They come and say, my kid comes home from school and for the whole afternoon, the kid just tics away, and I can't believe this is happening during school. This is very embarrassing. But really, the kid has been suppressing it all day, and what you're seeing is that it's now coming out. They're kind of releasing that. So it is important from an educational piece for parents to understand that. So when we define a tic disorder, we talk about less than 12 months or more than 12 months. If you're less than 12 months, you're a transient disorder. If you're greater than 12 months, you're a chronic disorder. You can have a chronic motor, a chronic vocal, or you can have one chronic motor and one chronic vocal tic. If you have one chronic motor and one chronic vocal tic, you have Tourette's. And this is like a bomb going off to say this to someone, right? People say Tourette's and they just go crazy. And I tell them, this is the definition. Your kid meets the definition. Your kid is no different than they were 5 minutes ago before I told you that this is the definition of Tourette's. So the definition Tourette's is 1 year of one chronic motor and one chronic vocal tic, both occurring. All right, so we're gonna look, unfortunately one of these stopped working, so we're gonna watch the one that works. This is an eye rolling tic, and it looks pretty significant. It's one of the more questionable ones, I guess I would say, that I've seen. So kid is engaged in reading or playing.
Jack and Sadie.
Is it fun?
He kind of deviates his eyes up and he comes back. He's still back to reading. He's back to doing what he was doing. Mom is talking to him. You can't hear that part, but mom is talking and he's kind of responding the whole time. So that makes it different than a seizure, right?
Island.
Very good.
No, that isn't my island. It's that guy's island.
Everybody appreciate that?
Go over his
Very good.
van.
Did you?
Okay. So transient tics are very common, up to 10% of children at least. I've seen studies that have higher than that. Tourette's is in about 0.5% they're going to qualify for the diagnosis. The tics do tend to last longer into adolescence and adulthood sometimes for kids who are in the chronic department, but overall they all do tend to improve with age. And we really don't understand what causes tics. Neurologically, what causes this, what pathway, we don't really know. We do know that the three major things associated with it are ADHD, OCD, and anxiety. And we know that sometimes children come to the neurology and they have a tic and they are a little anxious, they got a little OCD, that's okay. They need their tic treated. We also know that children come to neurology and sometimes they need a psychiatrist. The tic is really not the biggest issue. The OCD or the anxiety is the biggest issue. And so it is important to kind of tease out which one is really the most important because the tic is going to be a Band-Aid if we treat it from a neurologic perspective and you have uncontrolled anxiety. So education is the biggest thing. Some families are very happy knowing, hey, this isn't going to cause permanent brain damage. That's all I wanted to know. I don't want any medicine. I'm fine with it. I'll ignore it. Some people are fine with that. The first way that you treat tics is to ignore them. If it is not causing the patient emotional, social, or physical harm, it does not need to be treated. That includes if it is causing the parent emotional harm, but not the kid emotional harm, okay? So I will ask the kid in the room in front of the parent, is this causing you harm? Cognitive behavioral therapy is actually the next line. So it's that same idea as OCD. I think about it. I don't do the movement. What happens to me? Nothing happens to me, and I'm not going to do it, and it's okay. There are medicines. It's important to realize that the medicines reduce tics by about 50%. So it's not a magic cure, and it's important to know that ahead of time, or you'll get a phone call every week about how your tics have not been fixed, okay? So guanfacine and clonidine are our first line. Topamax has actually come out as a relatively good tic medication as well, and I've tried that one too. Really, when you get beyond that, you start getting into big gun medicine. So you start getting into medicines like tetrabenazine that you have to be on a special registry to order. I can't even write for it. And antipsychotics, which again, I have a discussion with the family. Is this tic so important that we're gonna have high lipids and we're gonna gain 50 pounds? Like, is this that important, okay? So I almost never write antipsychotics for tics because usually if your tic is that bad, you also have a lot of anxiety, other things that really need to be addressed before we go down that road. So stereotypies is a word that all of you need to know. Stereotypy is the answer to what is that weird movement my kid is doing? I don't know what it is, and you don't either, and you need a name for it. This is it, stereotypy, okay? So stereotypy is very common. Little kids do it all the time. We all have some too. I probably have some. They're repetitive movements. In infants, the most common thing is they're sitting in a high chair, they kind of flap their hands around, so kind of do that. That's a very common stereotypy. They may be simple or they may be complex movements. They are stereotypical but distractible. Again, they may be distractible for a second and not any longer. Kids have been EEG'd for less than stereotypies, okay? So it can be confusing depending, but often is triggered by something specific. So excitement or anxiety. Classic example of this is arm flapping in an autistic kid, right? That's the classic one, but normal kids have all sorts of stereotypies too. Videos are very helpful. A video is worth 5,000 words, at least in neurology, okay? Very helpful. They are very common in both developmentally normal kids as well as kids that are not neurodevelopmentally normal. They, again, may have some underlying stuff going on that you can explore. Really, psychological approach is the major approach if it is something that's causing harm. If you're headbanging and you're getting major issues from that, sure, then you need to try to work on it. But for the most part, we don't treat this, we reassure this, it gets better over time, and drugs are not going to help this. So this is really not something that we treat. This is a kid in the high chair, like I was saying, very common. They kind of sit there with their hands out and flap them around. That is a stereotypy. All right, so we're going to talk about acquired movement disorders. There's quite a few. We're going to kind of hit on the highlights of them. We're going to talk about HIE, infections, post-infection, stroke, lesions, and toxins that can potentially cause these. So first, acquired. The most common acquired movement disorder is going to be cerebral palsy associated with HIE type event, right? So this is going to be seen in children who are full term, who are not full term, who have an obvious brain injury, who don't have an obvious brain injury. It is important to realize that it can be all different types of children. I will warn you, the big pitfall here is that most children with cerebral palsy have cerebral palsy. However, as we have discovered more genetic mutations and understanding of metabolism and those type problems, we have started to realize that there are actually very rare, but a very long list of things that mimic cerebral palsy. And red flags for that would be kids who the story is that they were initially normal, that they were developmentally normal, and then they developed this, that it's progressing over time. That there's just nothing about their story otherwise that seems to go with it, not even an emergent C-section delivery, like nothing that goes with it. So just be aware that most kids with CP have CP, and that's correct. But if there's something strange about the story, there are a lot of things that can mimic CP. Infections, there are not a lot of movement disorder infections that directly cause the movement disorder. There are a lot of post-infectious ones, which we'll talk about. Japanese encephalitis is a big one. We're not going to see a ton of that, I hope. But EBV, strep, influenza, and enterovirus we might see, and they are some that more commonly directly cause a movement problem. But generally, we're going to see post-infectious problems or autoimmune problems coming out of infections. A classic, well-described one is HSV. Kids with a history of HSV encephalitis can kind of get an reawakening autoimmune problem, producing a movement disorder later on. That's up to 20%, so it's pretty well described. That's quite a few, actually. We also have a wide variety of encephalitides, and again, this could be my entire life's work, okay, just talking about this one topic. So it's a very big topic. But anti-NMDA receptor encephalitis is a fairly newly described problem. It is a problem that often presents with a movement disorder, often comes on suddenly on January the 1st, everything changed. Like that's this family, okay? They have behavioral changes, they have tics, they have OCD, they might be psychotic, they might have seizures, and all of it kind of came on suddenly. Previously high-functioning kid, everything just kind of went down the drain. That is a story that should make you think about autoimmune encephalitis, or a post-infectious problem. And anti-NMDA is by far the most common, but this is a very, very new field. We have been able to test for this antibody since 2007. This is the first antibody we've ever been able to test for. We now have a whole panel, but the panel is obviously expanding and changing every day. So the long term, if you're worried about this, serum and CSF workup and immunosuppression, it's a very big diagnosis, but a very important one to make if you think that's what the kid has. There are many others, like I said, they're expanding every day. And there's actually some that specifically target the basal ganglia, and then there are others that cause these autoimmune problems in a wide variety of ways. But movement disorder is often the presenting thing. The other thing I will say is, I did have a girl who had hemichorea. We did a EEG, it was not seizure, and she didn't have any of that. She didn't have psychosis, she didn't have behavioral changes, she had nothing. It had only been going on about less than a week, so that maybe is the problem. But anyway, got tested for this and had anti-NMDA receptor encephalitis. So do think about it. If you don't look for it, it won't be there. You won't find it. Classically, this has been associated with an ovarian teratoma. You might have heard that. But you see, as we've gotten more cases, that's not at all always true, especially in our age group that we deal with. So under 12, almost none of them had it, really, percentage-wise. The green is showing you ones who did have a tumor, and then the white ones are not. So this is not a female-only thing. This is not a you have to have a tumor thing. Sydenham's chorea is probably the best described autoimmune post-infectious movement disorder. It is the most common cause of acute chorea in children. We know it's associated with beta hemolytic strep, often with some behavioral changes as well, often will resolve over time. Sometimes we use low-grade immunosuppressive issues like steroids, things like that, to help in the short term. But if you listen to this story, I think it sounds a lot like an autoimmune story that I just told you. I kind of feel like this is in the same department and maybe was described 100 years ago, and now we figured out actually there's 300 others like it, okay? So kind of in the same vein, just well described and has a name to it. So now we're going to talk about the real elephant, which is pandas, okay? So pandas is a hotly contested topic, as you all probably know. And I don't really know that it should be. This, again, is in part my opinion. The stuff up here is recommendations that were online. I didn't make them up. But PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. In autoimmune clinics that have kind of sprung up for neurology in the last 10 years, it's sometimes called PANS because that kind of takes away the strep piece, like it's not associated with strep. You didn't have a strep infection. It is very uncommon. As I said, it's controversial, as you know. And I think the major reason that it's controversial is because kids come with all of these disorders, kind of like I just described, psychosis, OCD, tics, behavioral changes, and we blame it on this. The thing is, whether you have PANDAS or a different autoimmune disorder, the treatment is the same. So in the autoimmune clinic where I trained, the autoimmune team was a rheumatologist, a neurologist, and a psychiatrist. So if you have psychiatric symptoms, you need psychiatric treatment, okay? Even if it's because you have an autoimmune condition and also need treatment for that. And I think that's the big piece, is that people get pushed under the rug. So again, this phenomena sounds a lot like an autoimmune encephalitis to me. It sounds a lot like the other stuff we just described. This was described in the early to mid-90s. Remember I told you NMDA was the first one and we couldn't test for it till 2007. And so perhaps this is all really a spectrum that we're just kind of understanding. So PANDAS, kind of quickly here, is preceded by a strep infection. It has to be. They have to have OCD or a tic disorder. It's usually under age 12 when it comes on. The symptoms do wax and wane. They do get worse when you have a documented new strep infection. There is definitely an association with that, but that association, again, needs to be documented. And there is an association with neuropsych changes. There's a very abrupt onset, just like the other disorders we talked about, and they can have kind of quick worsening of their symptoms. So the treatment is to treat the strep infection. Again, you document it, not I had a sore throat 3 months ago. I wonder if that's what you have. A single course of antibiotics is very appropriate because you're treating an infection, just like you would if you didn't have a PANDAS kid with a strep infection. The triggers may, in rare cases, be a strep infection elsewhere in the body. So that's rare, but it is possible. When we treat these problems, again, as I just said, we'd use the standard treatment. So if the standard treatment for tics is clonidine, they need clonidine. It doesn't matter if they have PANDAS. If the standard treatment for their psychosis is an antipsychotic, they need an antipsychotic. IVIG is not a standard treatment. It is used in the big picture of the acute, really bad autoimmune cases. But this, like I get IVIG once a month for 3 years, that is no evidence at all for that. Elevated strep titers should not be treated with antibiotics. We know people are carriers, so that's not really evidence-based. And I think here's the biggest thing. I think we've all seen a patient at some point that was on long-term antibiotics for PANDAS. So if we think about PANDAS as an autoimmune condition, I'm not saying it's not real, I'm saying it's an autoimmune condition, just like all the others I've talked about, then that means the problem that is causing all of this stuff is an antibody. You don't treat antibodies with antibiotics, right? So that we're not treating the pathology when we're doing that. So I just want to make the point, because this is my chance, that treating a patient with antibiotics long-term, treating a patient or telling them they have PANDAS and that's why they have these other things and not addressing the other things is a major disservice to the patient, okay? If you have any of these things, it needs to be treated. If you have a different, like an NMDA encephalitis, that needs to be treated. That's a big deal, okay? But we do need to get the right diagnosis. Okay, so lastly, under this category, we're going to talk about progressive encephalopathy with rigidity in myoclonus, a very big word. The point of this is that there are people who have glycine receptor problems and they have movement disorders. If they're old people, it's called stiff person syndrome. They get very stiff. It can also be seen in neonates, and the neonatal kind of presentation is hyperklepkia, that word, which is actually being exaggerated startle or too jumpy. and over time they will become stiff. There is a version of that that can be triggered by infection that is autoimmune. So instead of having the underlying genetic abnormality that causes that, these people have an autoimmune version of kind of that has set off the same problem, okay? Okay, opsoclonus myoclonus syndrome, we've all heard of. I know you have. It's often thought about as a paraneoplastic syndrome. Very significant. You need to check for neuroblastoma, whatever else it could possibly be. I think if you actually look, there could be others. But it does not have to be. So it can be simply an autoimmune type picture that needs immunotherapy. So certainly rule out your scary stuff for underlying, but can also present as a primary diagnosis. So we also think about, when we're talking about acquired problems, stroke or space-occupying lesions. We just talked about a whole bunch of stuff that doesn't necessarily show up on MRI that could potentially cause significant new movement abnormalities. But anytime a patient has a new movement disorder, they really need imaging, and they really need an MRI with and without contrast. So we want to know, do your basal ganglia light up? Do you have a stroke? Do you have a vasculitis? Not all those things are going to show up on an MRI, but that's a good start. We're at least going to rule in or rule out and kind of know where to go forward from there. So you can certainly have focal movement disorders that come from stroke, vasculitis, tumors, as well as all of the stuff that we've just talked about. So toxins are also a big deal, both prescription and non-prescription. I obviously cannot list every toxin that could possibly produce a new onset movement disorder. But inhalants, toluene, certain forms of heroin, MPTP have all been kind of implicated in basal ganglia damage. There are lots of common drugs that we use that potentially could do that as well. Withdrawal can do that too. And environmental exposures are important to remember, especially the farming community. So organophosphates, heavy metals, methanol, manganese. I work in a factory. I'm a metal welder. All of that stuff is very pertinent. Also remember manganese in a TPN patient. So if there's something wrong with that, maybe they got too much, weirder things have happened. Carbon monoxide is probably our biggest, most famous kind of breathe in the environment one that's going to cause damage to the basal ganglia. And it specifically causes damage to the globus pallidus. I don't know about your boards. If you ever plan to take the neurology boards, you should memorize this. Okay, so this is like a really very famous, very classic. And the abnormality is the white spots. Okay, so these white spots are the basal ganglia that are essentially lit up because they're damaged. Okay. We're going to switch gears completely. We're going to talk about genetic movement disorders in a very general kind of way. Because again, this is a whole different specialty that you could devote your life to. Okay, so very general, just so that you know it's out there and you know that it's a possibility. So there are primary genetic dystonias. There's chorea, there's paroxysmal or intermittent movement disorders. There's myoclonus, ataxia, Parkinsonism, and a whole slew of neurometabolic problems. All of them can produce abnormalities of movement. When we talk about genetic dystonias, there's a system that it is kind of defined by called the DYT system. There are many forms, okay? There are about 3 that show up classically in early childhood or in the age group that we would see most commonly. That's 1, 5, and 11. Number 1 is a onset of around age 10. It's autosomal dominant, and the classic sign is inturning of the lower extremity. Not a kid who has CP, who now has a contracture, right? That's different. But a kid who is normal, who now their leg is stuck inward, okay? That's very concerning. The classic is Ashkenazi Jewish population, but obviously you should think about it if someone presents to your clinic with that. Type 5 are dopamine responsive, which is nice. We would like to discover those because they're potentially treatable, just like we treat Parkinson's disease with supplementation. And these are early childhood, usually in the limb, dystonic episodes that come on. Type 11 is a myoclonus dystonia combination. Same idea, starts around age 5, progresses over time. And there is a type 12, which is a dystonia Parkinsonism. So it's kind of it's almost like you wake up and within 2 weeks you look like you have Parkinson's disease. Okay, so you're a really stiff version of Parkinson's disease. So again, just know they're out there, okay? Just be familiar. So chorea is the same thing as genetics has really exploded in the last 15 years. We have found all of these different mutations that are associated with chorea. So there are some that are we know are associated with benign, and you can see them up here. There's some that we know are associated with progressive problems. There's some that we know classically present in children, and there's just so many, it's impossible for anyone to wrap their head around. So, but do be aware that this is very much a growing area. So you may find nothing on your MRI. It may actually be a genetic problem. Paroxysmal movement disorders, there are a lot, some associated with movement, not associated with movement. We're going to talk briefly here in a second about all of these, like a one-liner. Many of these do have medication treatments that are available. Some are better than others, depends on which one we're talking about. So paroxysmal kinesiogenic dyskinesia, that just means I have too much movement, right? And it is triggered by movement, all right? Do you guys remember, maybe I'm old, but do you remember when Michael J. Fox got diagnosed with Parkinson's disease and he came on TV and he was just moving and he couldn't stop moving? Okay, so that's a dyskinesia. That's what that is. He had too much Parkinson's medicine, okay? So that's what we're talking about, though. That's the picture. Non-kinesiogenic is going to be triggered more by stressors and anxiety, not actual movement. Also is going to last a few minutes to hours. There's an exercise-induced forms, again, same thing. Stress on the body, fasting, that kind of thing is going to bring on these dyskinesias in those patients. Alternating hemiplegia of childhood is a very interesting topic. They have episodes where they go hemiplegic or monoplegic, one arm, one side, whatever, but it's not always the same. So one side goes out, few seconds, few minutes, and the other side goes out, okay? And they are associated with an underlying ATP, like 1A3, a gene mutation that we see. Episodic ataxia 1 and 2, there's some other kinds as well, but these are the best described. Type 1 lasts for a few seconds to minutes, is triggered by stress. Type 2, a few hours to days, also triggered by stress. These are very interesting. The people will come and be truly ataxic. Like you see a video of them at home and they look like they're about to run in through the walls, okay? And it will come on and it will go away and they will be back to normal. And so it comes and it goes. And those are treatable if they're identified. There's myoclonus that can be related to genetic causes. We always think it's a seizure. It can be related to trauma or ischemic injury, but there's also genetic forms of it. And we talked about one briefly, which is the myoclonus dystonic syndrome with a genetic underlying abnormality. Ataxia, many different forms, again, of inherited ataxia. We're going to talk about the two that you would be most likely to encounter either in life or on a test. The first one is Friedreich's ataxia, and the second one is ataxia telangiectasia. That's what we're going to talk about, like one slide each. Friedreich's ataxia, so this is a genetic ataxia. It is the most common one. It is onset in children. It is autosomal recessive. They have a sensory ataxia that progresses. They ultimately lose their reflexes. They have speech problems. They're weak. They have trouble with their heart. They have trouble with their endocrine system. They have trouble hearing. And it is a triplet repeat problem. So definitely one to know, most common one. Ataxia telangiectasia is also relatively common in my world. All of these are more common in your world maybe, but relatively common. We do have a patient with this in our clinic, so it's not uncommon. It is a little tricky because the telangiectasias show up after the ataxia. So you think like, oh, I'll just look and see their telangiectasias. No, you won't. So the telangiectasias show up around age 4 or after. The ataxia first shows up when they begin to walk. So this is a toddler that's more wobbly than usual, which we get asked that I think every day. And that is very difficult because you're like, yeah, they look normal. But if they should be progressing and they're not over time, this is something that you should think about. You can screen for it with AFP, so elevated AFP. And these kids have a lot of other problems too. The ATM mutation is a problem with DNA repair. And so what you end up with are kids that have immunodeficiencies or kids that have leukemias and lymphomas. Some of their family members who are carriers, like mom is a carrier, is actually at risk for some of those cancers as well. And so they have a lot of issues, very big. I mean, like I literally have a lecture that's on like this and 3 other things. So very big topic. All right, then we have Parkinsonism. So remember at the beginning we said we have decreased movement types as well. And these are going to resemble your idiopathic Parkinson's that you think about in older people, but are in younger people. They can, like we said, have dystonic components or chorea components. They can come on at very young ages, including in teenage or younger. And there are many causes of this, again, depending on your genetic abnormality. Lastly, under the genetic group, we're going to talk about neurometabolic syndromes. This is a huge topic. These are blood tests. These are CSF tests. You know those little tubes? Who's on LP with me? Those weird little tubes that go on dry ice and you all roll your eyes, you know what I'm talking about? Though, that's what this is testing for. So these are testing for that, like, oh my gosh, I can't believe we're doing this. That is what this is for. So these are the neurotransmitters, and if they are, certain ones are up and certain ones are down and they fit a certain pattern, you may be able to diagnose one of these conditions based on that. So the treatment depends on which one it is. Unfortunately, a lot of those treatments, like many of the metabolic diseases we've discovered in the last 10 years, are symptomatic because we just haven't gotten there yet. And we're certainly going to be treating the movement disorder part of it, just like we would treat any movement disorder, even if we can't fix the underlying cause. Lastly, we're going to talk about our favorite psychogenic movement disorders, which are very real and happen a lot, okay? There is a significant percentage of these, especially in acute presentations, because most of the stuff we just talked about is going to kind of come on. So it started 3 weeks ago, it's been gradually getting worse, or 3 months ago, the exception to that being the autoimmune encephalitis that we talked about. These are going to be tricky. Some of them look like they're psychogenic and some of them don't. Some of them are very hard to figure out. They're most common in females, they're most common in adolescents. The hallmarks of this, and I would say that these compare to psychogenic epileptic problems too, they're very similar, is that they come on suddenly, the onset is explosive. So it first happened 3 days ago, and now there's 50 a day. Okay, that's pretty abnormal for a non-psychogenic, possible, but abnormal disorder. So the rapidity with which it gets to its severity is important. The changing characteristics are important. If you ask them in clinic to talk about themselves or tell a story or spell their name and look at the ceiling and do all the stuff at the same time, the frequency of the movement will change. Sometimes it will stop, and so you can tell it's changing over time. And then lastly, their abilities are inconsistent with the movement problem. So maybe they have hemichorea and they're flinging their arm around, but they can use their phone, right? So things that you really shouldn't be able to do. Most common are pseudotremors and pseudomyoclonus, but certainly anything is possible, so any of these departments. These are classic, just like in many of our other related conditions in high-performing academic students or sports folks. They are very anxious. A lot of times they have certain stressors. The JV football team is a true story. So 10th grader comes to clinic. He has made the JV football team. He did not make the varsity team. He's the quarterback, and he has a pseudo-tremor in his arm. This is like August. So he can't play because he has a tremor, not because he didn't make the varsity, right? So this happens. So the approach is similar to a pseudo-seizure. It is a problem. You want them to understand and feel like it's a problem, but it is a problem. If they can't go to school, they can't go up the stairs, they can't do their homework because they can't write, I mean, it is a problem, okay? It's just not a primary neurologic problem, but it is a problem. So reassurance is important. Trying to address the underlying triggers, if possible, is important. Unfortunately, a lot of these people are going to get a workup, because we just spent the last hour talking about the weirdest movement disorders that come on in the weirdest way, and so what are they going to get? They're going to get an MRI, unless it is obvious. If they come in your clinic and you clearly can distract them and it clearly changes and it is just different over time, maybe not, but most of them are probably going to end up with one. Ultimately, reassurance is going to be the major thing. We had a kid this week like this. And I said to her, we may never know what causes this, because she's already had $1 million workup by 4 neurologists combined. And however, the important thing is that you have to get back to functioning. So if this happens for the rest of your life, you have to function. So the goal and the focus is on, you got to go back to school, you got to go back to your activities. Sometimes they end up in occupational therapy or physical therapy, really with the goal of trying to get them back to functioning, to get them walking again, to doing whatever. And then a second opinion, or a third or a fourth, as you heard, opinion can be helpful, because certainly the fact that no other workup is needed, the workup that we've done is complete, is probably going to need to be said by other people. And so sometimes it's going to come down to either you being the second opinion or telling them it's okay if you want a second opinion. And that is it. So any questions are welcome. Yes, ma'am.
I know we recently had a kid with a shuddering spell that we texted about. Is it helpful to you for us to video the kid with the parents' permission get that off of the EEG?
If it happens on the EEG, we will get it. Because we have video with all of them, and so they'll document an episode happen. That's probably ideal. If we're to the point that we're not sure and we're doing an EEG because we can compare the spell at the exact same time as we can compare the brain. Otherwise, though, videos are helpful. And so, we ask patients all the time, like, that sounds weird, I don't know what it was, but next time, if it happens again, try to video it. So it can be very helpful if it's just hard to describe. Anybody else? Yes.
I get kids with throat clearing. So is it okay to send them to you if clinically it looks like it's a tic and not reflux? Without doing a workup?
Oh, that's up to you. That's up to you. If,
Start talking about
yeah.
it, start throwing
Yeah. I mean, if you think it's a tic, and there's a tic, yeah, definitely. Yeah, that's true. Ignore it first.
I'm getting a history and then all of a sudden
Yeah.
it's fine and all of a sudden they start
Yeah. Yeah. I mean, yeah, if it's a significant issue for them, if they've come to GI, it's probably a significant issue, right? It hasn't been ignored. So yeah, I mean, it's probably a vocal tic. Okay, well, thank you guys for coming and listening.